Hi, Dr. Michael Miyazaki again, and today we're going to take a little departure away from endo and resto and peripatet and talk about function. Now, before I lose you there, just want to remind you that function is a very important part of what we do. Every day when I do my work, I'm testing the patient's bite, making sure that when they bite down, everything is sitting evenly. But I want to tell you about some things that are really rewarding about what we do. I've had patients that have been coming in more than ever, maybe it's post-COVID, I don't know, that have been coming in with all kinds of different pains. Some are true bite pains, some are endodontic pains, and some are those TMD types of pains. And I will tell you, one of the things that happens is when you solve the issues that are causing these patients pain, they appreciate it like nothing else. So I've had patients that have been coming in and complaining about pain in the lower jaw, and we can't pinpoint it to one tooth, but it's this region down here. And a lot of times what it is, it's muscular pain. They've been clenching, they've been grinding, and what that type of pain is it's very diffuse, and the patient can't just say it's this tooth here. And so we'll ask the patient for some patience. I don't want to start doing root canals on teeth unless they really need root canals, but when I tap on the teeth, they're all pretty much the same. When I do cold tests on all the teeth, they're all pretty much the same. So it's really hard for me, even radiographically, to discern what tooth could be causing that pain. And so I ask them, have you been clenching or grinding? And they say, yes, I've been clenching. There's something in their life that is causing this stress. And so I ask them, is it okay if we take the notes that we took today, the radiographs that we took today, and we have you come back in a week or two and we'll compare and we'll see if things are still that bad. Because sometimes it's just like if you and I go out and we run and we're not really runners. If I go out and run a long distance, then my legs can be sore. Now, it doesn't mean there's anything wrong with my legs. It's just I've overused my legs and that's why they're sore. And so if you've been clenching or grinding, these muscles can get sore. They can make the teeth feel like it's tooth pain, and it's really not. So would you be okay? And I've had patients that come back weeks after that first visit where they're sure they've got some kind of pain that needs antibiotics. And I tell them, let's just take it a little easy. Let's go a little slow. Let's just have you stay on a softer diet, a non-chewy diet. You can put warm compresses, moist compresses on the muscles here because this is where it's sore, right? And they go yes. It could be on the zygoma here, if the masseters or the angle of the mandible, and they've just been clenching, or maybe it's over the temporalis area. And if that's what's going on, then they're very appreciative that we didn't jump in and start grinding away on their teeth to even out their bite or give them medications or antibiotics or do anything that was too extreme. It just took a little bit of time. And then we do have the patients where they do have bite issues. Their bite is off, and because their bite is off, they have joint pain, they have muscle pain, they have tooth pain, and all kinds of different things. And I had a patient like this last week, and she came in telling me that her bite was off. And, I was a little hesitant to do anything. And I'll show you some photos from her case today, too, because I wasn't sure what was causing the discomfort. Really, was it because she didn't feel like all her teeth were hitting and she had an even bite? Could that be causing the types of pain that she was having? And I'll tell you, the end of the story is I looked at her bite and she had some non-working interferences, and I thought that could be the key. But I listened to her. I did lots of different things, and we even tensed her to try to relax the muscles and figure out how her bite was when the muscles were more relaxed. And she came in and she said, I just need my bite evened out. And I'll tell you about what we did, because when I have a patient that tells me they have an uneven bite, what I try not to do is I try not to take a burr to their teeth and grind teeth down, because what happens a lot of times, a patient will come in and say, you know what, this tooth's hitting too hard. And what we do is we grab our handpiece with a big coarse burr and we wipe that high spot out after we have them tap tap on some articulate paper, right? And we see that big dot. I will tell you that can lead to a lot of things we don't want to have happen. A patient comes back and says, you know what, I don't feel any better. Maybe actually they feel worse, and you've done something irreversible, and they hold you to that. Remember, you took that burr and you ground my tooth down, and now because you ground my tooth down, my teeth don't come together right. So I try not to take tooth structure away. With the patient I treated last week, what I did is I told her I'm not going to take any tooth structure away, but I'm going to add to your teeth to even out your bite or to improve your anterior guidance. And I was explaining to her what anterior guidance means. I even showed her videos. And I told her, worst case scenario, we can take this material off, but your teeth are going to remain the same as they are now. So what I want to talk about is more function. Because when we talk about occlusion, occlusion is more how the teeth come together. So when I talk about occlusion, I'm talking about the teeth coming together and the teeth functioning. And many times we as dentists, we focus on our patient, the teeth, and the gums, right? That's our main area of focus. I'm looking for decay, I'm looking for gum disease, I'm trying to manage that. And so we focus on this very narrow area. But what I want you to understand is that what we want to do now is we want to look at the teeth, the patient, and that is the occlusion. But it's so much more now because the teeth will affect the patient's muscles, the teeth will affect the patient's jaw joint position, and the teeth will be affecting the central nervous system. And so there's so much more than just the patient, the teeth, and the gums. And that's what I want us to focus on. And I know I'm going to keep it moving quick. And I only interject this in between all the fun endo-resto preventative information I present. But I hope that makes it more painless. So what I want to do is I want to start with vocabulary, because unless we're speaking the same language, it's going to be hard to share ideas. So if I'm talking to somebody who only understands, let's say, Spanish, and I'm only understand English, it's going to be hard for us to convey ideas unless we learn each other's language. So I'm going to go through some terms, and every time we talk about occlusion, which I intersperse between all the other subjects, hopefully something sinks in. But I want you to understand that even myself, I operate kind of on the dot level. And what that means is that I do a restoration, a direct composite, a crown, an implant, a denture, and I always place articulating paper in the patient's mouth and I have them bite down and sometimes grind. And what I have to remember is that the intensity of the forces can't be determined by the size of the dots that are left on the tooth or the restoration of the denture or by the intensity of the color. That what I try to interpret is what the forces are on the teeth, because the forces are going to maybe dislodge the denture or cause pain when the patient is biting down or grinding. So it's so much more than the intensity of the dots themselves. So what we're going to do is look at where the dots are and what are these dots doing. The dots in this area and the dots here, they're not the pinpoint dots that we want to have on the cusp tips, let's say, that are going to verticalize the forces, but these are going to deflect the forces where we are going to, in this case, protrude the mandible. So when the patient hits this is an orthotic that we have that looks like teeth, feels like teeth, but when the patient bites on this, those dots are going to cause the mandible to go distally or go back. And that may not be what we want to have happen for that patient. So when I look at a patient like this, where there's a lot of occlusal wear, this is kind of beyond the level of the dots, right? We need to figure out why this patient's wearing their teeth down like this. So that is beyond the level of the dots, but that's the exciting part. Now, what I want you to understand is when I look at a patient like this, I'm not thinking full mouth rehab. It's not really what I want to do, but it may be what we have to do. But remember, the goal is not to do a lot of restorations, but it's to figure out what's the most conservative way I can restore this patient's dentition and stabilize the bite so they don't end up with TMJ or TMD. And the purpose of these presentations is to take on the perspective of a restorative dentist. But remember this information, because I know a lot of you today are treating TMD and treating airway issues. And so this information can help. What I want to impart upon you is knowledge that will empower you so that you're not like the dentist on the left-hand side kind of throws their hands up, but you're the dentist on the right-hand side that says, yes, I got this, I can handle this. So one of my occlusion mentors was Dr. Peter Dawson. And Dr. Dawson said occlusal disease is a major cause of excessive tooth wear, tooth fractures, hypersensitivity, and masticatory muscle pain, plus a whole plethora of signs and symptoms that oftentimes doctors just mask out with medication. But we'd rather take care of the cause than to mask it. So dentists need to be trained to diagnose and then treat all of these problems. What's really scary is if we don't understand how the system works, we don't know that we're not the cause of the problems that our patients are having. And I think that's the important part. So just to run through some definitions today, and as we go through this in the next couple months, hopefully more of it will sink in. But what we're trying to achieve is what we call anterior cuspid guidance. And that's just when the patient goes in the lateral movements that the canines, being longer and pointier, disclude the posterior teeth. And if we disclude the posterior teeth, the elevator muscles, about 2/3 of them are shut off. So we can put less pressure on the anterior teeth, but we put less pressure on all the teeth overall. So if the posterior teeth are hitting, we are trying to crush our food. At least that's what the body thinks. And so our masseters can really clench down. But if only the anterior teeth are hitting, we can't clench down as hard because we don't want to break those teeth. Group function is when we go into lateral movements and all the teeth in the posterior, maybe even the cuspid, are all hitting all at the same time. So it's usually unilateral, and it's a unilateral balanced occlusion, meaning when we slide over to the right-hand side, there's a bunch of teeth in the back, not just the cuspids, that are hitting. So this can encourage more wear. We're transmitting more lateral forces onto even the posterior teeth, and we don't want to do that. So again, lateral forces can injure the teeth, as we all know. We don't want to have those lateral forces. Working side, that is the side to which the mandible is working. So if I had, let's say, an apple in my hand, I'm being right-handed, and I bite into that apple, and I'm going to do most of my chewing on the right-hand side, my mandible is going to swing over to the right-hand side so the teeth line up, and that right-hand side is called the working side. The left-hand side, the side that my teeth are moving away from, is called the non-working side because I'm chewing on my right side, and so the right side is working, it's chewing. The left side is not working. So I've got whichever side I'm swinging my jaw to, that's my working side, and the opposite side is the non-working. Now, with dentures, sometimes we have what we call bilateral balanced occlusion. So remember, balanced occlusion is where all the teeth are hitting on that side, not just the cuspid, which is anterior guidance or disclusion. So perhaps with dentures, because we don't want the denture bases to tip, anterior guidance can do that. As the patient moves laterally, we want all the teeth to touch, the teeth on the right side and left side, so that one side of that denture can't tip up, and we want all the teeth to be hitting, not just to have anterior guidance. Now remember that our head is about an 8-pound bowling ball, and when it rests over our shoulders, we're pretty balanced over the spinal column. So the muscles of our neck and of our musculature at the back can basically be more relaxed, right? Because it's balanced on top of the spine. But as soon as our head starts to tip left or right or forward, we call forward head posture, now these muscles are straining more because they're having to support this bowling ball that's further forward. It's like that leverage arm. If I've got a ball and I'm holding it straight up and down, my arm's supporting that ball. But as soon as that ball starts to lean forward, now my muscles have to support that weight, but that weight is amplified by the leverage of that arm and the distance my arm has to be extended. We don't like that. The neck doesn't like that. So one of the first things I'll do when I'm doing my TMJ examination is I'll put my fingers over the patient's jaw joint and I'll say, can you open and close? Open really wide, close. Open really wide and close. And I have my fingers on both sides. I'm trying to listen for joint sounds and I'm trying to feel for joint sounds. You don't know how many times I ask a patient, do your jaws click or pop? And they go no. And then I put my fingers over their jaw joints and I ask them, can you open and close? And you hear all the crepitus or you hear this loud pop. And I ask the patient, did you hear that or did you feel that? And they'll say, yeah. You know, I've never felt that before, but I felt it that time. The problem is if they're not aware of that, and let's say you do that occlusal sealant on tooth number 19, and then after you do that sealant, they notice that click in the pop because they've been at the dental office. They're more aware of what's going on with their jaw joint. They come back to you and say, you know what? Ever since you did that restoration, that little sealant down there, my jaws have been clicking and popping. If you have in your record that was a pre-existing condition, now you look back at your notes and say, oh, you know, Mrs. Patient, remember when we discussed that, your jaws were clicking and popping at our last visit. It takes that monkey off your shoulders. Then we've got the muscles of mastication, the masseters, the temporalis, the lateral pterygoid, and the medial pterygoid. Now, the masseters are the powerful chewing muscles. Those are the ones that the patient's been clenching all night. They'll be sore, typically at the insertion at the zygoma or the angle of the mandible. They're the elevators. They're the ones that when the teeth come together, the body says, okay, I've got to chew through that steak, and you can generate a ton of power to chew that steak up, right? So it's an elevator muscle. Now, the temporalis is a little bit different. that's a coordinator of the final closing movement. Because what do we have with the anterior temporalis? Is we got fibers that go straight up and fibers that go back. So we've got different directions these fibers can pull, plus we've got one on each side, so we can move left or right, forward or back. And so it really is coordinating where the jaw is moving towards, and before the teeth touch, the masters aren't doing a whole lot. The temporalises are elevating the mandible. And then once the teeth feel something between them, then the masters are activated. The lateral pterygoid has two parts, the superior head and the lateral head, and they're tied to the condylar head, or the top of the jaw bone, and the disc. So the superior head and the inferior head are really involved with moving the jaw forward and backwards, and moving the disc along with that. The medial pterygoid is kind of on the inside of the mandible, kind of similar to the masseter, so it elevates and protrudes the mandible. And there's one on each side, so it can work to move the jaw side to side. So I just want to discuss really quick and give you a quick appreciation of how the muscles work, the definitions of what working and non-working are. And what we as dentists have to do is we have to understand how this system works, so we can recognize when it's off, why it's off, and then manage occlusal disorders so that we don't create any problems that would cause our patient's stomatognathtic system to worsen, to develop TMD, or to break more teeth. What we want to do is we want to get the occlusion in harmony, so the teeth, joints, and muscles, and the central nervous system working with those three parts can be pain-free. And if we can get that to work together, we're going to decrease the wear, we're going to decrease the restorative work the patient's going to need, because they're not going to fracture it or break it. And our work is going to be more predictable and will last longer. And that's why what we want to do, or what I want to do, is I want to make occlusion to work for you. I don't want it to be something that we're scared of, but I want it to work in your favor. So when you look at a tooth tomorrow at the office and you see a little chip like you see on the front left central incisor here and the front right lateral, what I want you to do is think, before you restore that, if the patient wants you to restore that, now why did that happen? So we always have the cause and effect. And what I want you to do when you go back to the office is, when you see wear, inform the patients that there is that area of wear, and then figure out why that wear is there. So I feel like even if we're not going to treat signs of wear, that our job is to tell the patient, hey, you've got some wear. You worn all the enamel off your incisal edges. You've got dentin exposed, or you've got class 5 lesions from the teeth being rocked side to side, not from a toothbrush, but from occlusal pressures, and we've got recession in that area. I think what we have to do is we have to tell the patient what's happening in the mouth, maybe what we could do to help them. Maybe it's as simple as a night guard. I mean, I know many of my colleagues just say, hey, I can give you a night guard to protect the teeth at night. And others of my colleagues would say that we can move the teeth to a more protective form of occlusion. There's many different levels depending on where your comfort level is. But what I want you to start doing is I want you to look for signs of occlusal instability, worn teeth, broken teeth, loose teeth from fremitus. When they bite down and they're chewing, the teeth have some mobility. Look for those types of signs and symptoms, and then try to figure out, you may not even bring it up to your patient at this point, but try to figure out what's going on, and then tell the patient, okay, we have signs of wear and tear. And what that means is wear, or occlusal wear, is a degenerative, non-reversible sign of disease. And what I want to do is I want to either restore your teeth, give you a better bite, maybe treat their TMD, but try to figure out what you can do to actually slow that occlusal wear down. Maybe it is just a night guard. Every patient's going to be a little bit different, and that's what gets to make this a little bit challenging. Some have some financial constraint, some are already wearing a night guard, some you can make them a night guard and they'll never wear it. But that's where this gets to be fun. We are creating a community of like-minded professionals where we can share these ideas. And I know I'm getting into some subjects that are kind of a little bit deeper, because I want to increase your understanding so that your practices both grow and thrive. If you like this information, hit the like. If you want to subscribe so you don't miss anything, hit subscribe. We would love to see you become part of this community. And one, I really appreciate you all taking the time to watch these programs. I'm trying to mix it up, but again, give me some suggestions if there's something that you really want to learn, or you've got something more to teach me. It goes both ways, and I just really appreciate you being here. So thank you very much. And when I get back to occlusion, and it may be a little over a month from now, we're going to get deeper in and build on this information I've given you today. So thank you very much, and take care.